Okay, ma'am, it is sharp 3 p.m. So, with all your permission, I'm starting the session. Good afternoon and a warm welcome to all the dignitaries present here. Myself, Rupsha from Clirnet, assigned as a session assistant to ensure a seamless experience. Clirnet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clirnet is the digital partner of this event organized by Oncology Integrated Society, and the topic of today's session is Approach to Adnexal Mass. So let's begin today's session, for which I would like to invite Dr. Diksha Chaturvedi, ma'am. Over to you, ma'am. Kindly proceed with your talk.
Thank you so much. Good afternoon, everyone. I would like to welcome all the experts, chairmen, and participants to the next episode of Cancer Webinar Series of the Oncology Integrated Society, supported by Dr. Chaturvedi Cancer Hospital Gorakhpur and Clirnet Team. A very warm welcome and greetings to all. Today's topic, as already told, approach to Adnexal Masses by a very intelligent and down-to-earth ma'am, oncologist, Dr. Swati ma'am, from Vaishali, Max. So a brief introduction to the subject is that the actual incidence of the adnexal masses in general population is unknown, since mostly they are asymptomatic and undiagnosed, usually detected on physical examination or imaging modalities. Less common adnexal masses may be presenting with symptoms as acute or intermittent pain, often ignored by the patients. Adnexal masses seen in premenopausal women include ectopic pregnancies, ovarian cysts, polycystic ovaries, adenomatous, and tuber-ovarian abscesses. Most common ones are follicular and corpus luteal cysts. Most adnexal tumors are benign, but a certain percentage are malignant. Mostly, a postmenopausal female population will have a higher risk of having a malignant adnexal tumor than premenopausal. So here we are to know when and how to differentiate, derive conclusions as to what type of adnexal mass needs attention. And for that, we have our eminent chairpersons, renowned speakers to detail topics. The chairpersons are Dr. Reeta Singh, she is an associate professor at the RD Medical College, Gorakhpur. She is the past scientific secretary of GOGS and scientific secretary in 2022. Our second chairperson is Dr. Dipti Chaturvedi ma'am, MS Obs and Gynae Gold Medalist from GRMC Gwalior, past member of Executive Body GOGS Gorakhpur, IMA WDW Society Head, past executive member UP IMA WDW State Chapter, Vice President, past Scientific Secretary GOGS, past Secretary GOGS, past Joint Secretary GOGS, Joint Secretary ISOPAB, present member of IMS and UPSC AGOI, received award for appreciation in cancer awareness programs from IMA Gorakhpur, co-director, proprietor, consultant of Dr. Chaturvedi Cancer Hospital Gorakhpur, member of Chief Organizing Committee in UPROI 2011. Would like to welcome the expert, Dr. A.K. Chaturvedi sir. He did his post-graduation from Indian Medical College in Goa, proud owner of Dr. Chaturvedi Cancer Hospital in Gorakhpur, past president of UPROI, trained at Manchester Memorial Sloan Kettering Cancer Center, New York, US, Christie Hospital and Radium Institute, Manchester, UK, Royal Wanford Hospital, Exeter, UK, Dr. Daniel Den Hood Cancer Center, Rotterdam, has been co-guide to many cancer theses of BRD Medical College, Gorakhpur. He has many awards and publications to further his career. All the participants can put their questions in the chat box, which will be answered in the end of the session. Some videos too will be shown at the end to make the webinar more interesting. So kindly stay with us. Now, welcome all the dignitaries for lighting the webinar.
Ma'am, should I play the video of lamp lighting?
Yes.
Ma'am, just allow me some.
Now I would request Reeta Singh.
Yeah, good afternoon to everyone. First of all, I would like to congratulate Dr. Dipti ma'am for organizing the webinar on a very important topic of adnexal mass. Adnexal masses, they are now very common in women of all age group, but when they are present in adolescent and in postmenopause, they are more challenging to diagnose and manage these patients. So one have to be very methodical preoperatively to when to open and when to not open, when not to do surgery in such patient, and the clinical approach to make a correct diagnosis. And so for that, we have a very eminent and experienced oncogynecologist, Dr. Swasti. She is a renowned laparoscopic and robotic surgeon, gyne-oncosurgeon at Max Institute of Cancer Care, Max Super Specialty Hospital, Vaishali, and Patparganj Max Multi Specialty Center, Noida. She did her robotic surgery fellowship from Wales and did training from Sweden. At present, she had also contributed as conveyor at Delhi Gynae Oncology Group 2021 to 2024. She is member of Adolescent Committee, AOGD Executive Member, New Gynae Forum Southwest, ex-member Oncology Committee, AOGD. And she has many national international publications in national international journals. So I welcome ma'am, Dr. Swasti ma'am, to share her experiences with us.
Thank you, Dr. Reeta, for your kind words. And with the permission of all the chair, I would like to begin today's session. I hope the slides are visible.
Yes, visible.
So,
Yes, it is.
as all our dignitaries have mentioned today, that adnexal masses pose a lot of dilemma in diagnosis as well as management to the gynecologists, and they are a very common occurrence in a gynecological OPD. So, half of the solution to any problem lies in defining the problem. Whenever we encounter an adnexal mass, the contention is what is the origin of the mass, how we should approach it, what investigations which we should do, is it cancer or not, how to manage these masses, should we operate, is surgery the right approach? If yes, then what should be the route of surgery? If a woman is young and desirous of future conception, fertility preservation becomes a significant issue to deal. And nonetheless, but most important is the oncological safety, which should never be compromised in the management of an adnexal mass. So, from pre-pubertal to post-menopausal, we see girls, young children, and um, elderly ladies with these masses. So there is no restriction to age in women with an adnexal mass. We've dealt with masses in girls as young as 3 years to 4 years. We all know the younger girls will have more of germ cell tumors and other adnexal issues. So a very thorough initial assessment is mandatory. A thorough history. We know that ovarian cancer doesn't have very significant symptoms. So most of the symptoms are usually vague. So whatever symptoms, whether it is pelvic pain or changes in appetite, changes in bowel and bladder functions, or urinary issues, or constipation for that matter of fact, must be elicited and noted. Any change in menstrual pattern has to be also noted. I'll discuss why in subsequent cases. Also, there are certain risk factors like genetic mutations. So, a family history of breast, colon, uterine, or ovarian cancer to elicit Lynch or hereditary ovarian cancer syndrome has to be also noted and dealt with in detail. So, when we examine these women, a general abdominal, vaginal, and a rectal examination becomes very, very important. And a breast examination is also very important. I just saw a lady with postmenopausal bleeding, and when we examined, there was a suspicious thickening in the breast, and it came out to be a Barrett's 4 lesion and is now undergoing a biopsy with some suspicious axillary right-sided lymph nodes as well. So, our comprehensive examination can also pick up synchronous malignancies or double primaries as well. Now, this is the IOTA classification, the International Ovarian Tumor Analysis classification, a basic after examination. And the first step is moving towards a non-invasive, commonly available investigation, which is an ultrasound, abdominal and vaginal if possible, if the woman is sexually active, and otherwise a transrectal or only an abdominal. In very young girls, sometimes transrectal ultrasound also becomes a challenge if you don't have the specific probe. So, what are the ultrasound features which characterize malignancy? So, you could have solid components, presence of ascites, papillary structures, or tumors larger than 10 centimeters with a solid component. And the hallmark is neovascularization. So, the hallmark for cancer is neovascularization. If you have a demonstrable strong blood flow within the lesion, then it definitely predicts a malignant tumor. So this is a 31-year-old lady with a mature cystic teratoma. You see a complex ovarian cyst, some low-level echoes, and there's a solid appearing area with a faint distal acoustic shadowing. And the mass, this lesion, there's a 40-year-old, the mass actually doesn't have any demonstrable blood flow. The blood flow that you're seeing is the blood supply to the ovary. And there's a solid area within the mass, probably a blood clot. This is a hemorrhagic cyst in a 40-year-old. This is a 38-year-old. You could see blood flow within the solid nodule. And this is finally came out to be a serous cystadenocarcinoma. So whenever your ultrasound is indeterminate, that means you're not able to characterize the lesion well, you move ahead to doing an MRI. Particularly in younger women, we don't prefer CT because we don't want more of radiation exposure. We prefer doing an MRI to characterize lesions as well as pick up a mental or other peritoneal disease as well. Now, more complex lesions, MRI is preferable. PET-CT is not available everywhere. Sometimes when you're seeing a lot of ascites, solid cystic mass, and you think that this is probably heading towards malignancy, then you could also do CT because MR also may not be available in certain cities. So CT with contrast or MRI with contrast as a second step, and PET-CT if as a one-stop investigation if it's available. So in a 28-year-old, this is the MR imaging of a serous borderline tumor. You see there are very small solid nodules, very small peripheral solid nodules, and largely the lesion is cystic. So there's some sort of free fluid in the pelvis, but that's not related. This is a 44-year-old granulosa cell tumor. Almost the entire ovary is replaced by the tumor. And you see some microcystic components within the solid components. And there is no normal ovarian tissue. Now, this is a 44-year-old. You could have granulosa cell tumor in a 28, 30-year-old also. And there is a lot of discussion or debate, can you save this ovary or not? So the MR actually, when you look at the image, you will be able to guide the patient and make her understand that probably saving of any part of this ovary is not possible because the entire ovary seems to be replaced by the tumor. So the MR also guides you to taking a decision between a cystectomy versus a salpingo-oophorectomy, unilateral. Now, also, when you think of large lesions more than 8 to 10 centimeters, then probably doing a cystectomy is really not worth the thing when there is no normal ovarian tissue. Then it just unnecessarily causes spillage or leaving behind the tumor, which is not a favorable thing to do. This is Krukenberg, very typical. CA stomach, bilateral solid cystic ovarian masses, 42-year-old. And these are CT images. Both sides are almost 5 to 6 centimeters in size. And this is definitely Krukenberg. So when you see bilateral lesions, please also think of other primaries and other malignancies like stomach, other GI malignancies, and of course, breast cancer. So this is a complete imaging of the abdomen and the showing serous adenocarcinoma. This patient has a lot of root of mesentery involvement. There's a lot of non-resectable disease in the mesentery. So what I was trying to also say is that other than the characterization of the lesion, if you're suspecting malignancy, you want to understand whether you can go ahead with upfront surgery or not. imaging is important. And that's where we utilize imaging to understand whether we can go ahead with surgery or not. Because our aim in ovarian cancer is to do upfront reduction and taking out of the surgery completely. So this is an incidental ovarian cancer in a 59-year-old. This is a PET-CT image. You have an FDG uptake, hypermetabolic lesion in the right ovary, which has ovarian serous cancer on the final histology. So these are areas where you could find ovarian cancer, mesenteric disease, extra-abdominal disease, liver parenchymal disease are areas which come under non-resectable lesions, and these have to be biopsied, and then upfront we start with neoadjuvant chemotherapy and then proceed on with interval cytoreduction and surgery to remove ovarian cancer completely. So the aim in ovarian cancer is to surgery is to remove the grossly visible disease. No disease should be left which should be visible to naked eye, and that should be the aim. So one more important aspect is role of tumor markers. Now, I see a lot of tumor markers being done to women, CA125, Roma, CA19.9. So which tumor marker has what importance and when we should do which tumor marker? And can a tumor marker predict whether the lesion is benign or malignant? Can it predict whether this patient needs surgery or not? We'll just go through this. So a tumor marker is not a diagnostic test. It carries prognostic value. CA125 was more specific for postmenopausal women rather than premenopausal women, because we know that CA125 goes up in normal menstruation also. And a lot of benign conditions like PID, tuberculosis, pancreatitis, pulmonary effusions, pleural effusions, and other kind of things. So in premenopausal women, things like endometriosis and malignancy also mimic, and a CA125 could be raised in both. So a rise in CA125 in a premenopausal woman is not as sensitive as it is in a postmenopausal woman. But wherever there is a rise in CA125 beyond 200, then definitely it holds value. So LDH, AFP, and beta HCG are three markers that we do in all younger women, all women less than 40 years. And wherever we have bilateral lesions, we always do CEA. And whenever we suspect mucinous lesion on an imaging, then we do CEA and CA19.9. So CA19.9 also goes up in all the hepatobiliary lesions and pancreatic lesions, and also CEA is a marker for GI. So if you have a raised CEA, always have to do endoscopies, upper GI and colonoscopies to exclude a GI primary. So we know that Krukenberg is not always bilateral. It's not 100%. It's 90% bilateral. 10% can also be unilateral. But definitely in bilateral lesions, must exclude Krukenberg before you take patients for surgery. So risk of malignancy algorithm is a combination of HE4 and CA125. It's calculated by a logistic regression algorithm. And if it's more than 13.1% in premenopausal or 27.7% in postmenopausal women, it is indicative of a high risk of malignancy, because CA125 alone may sometimes be not so sensitive in premenopausal women. So when we calculate risk of malignancy index, this is a very specific marker. And basically, you multiply the absolute CA125 values to menopausal status and multiply by the ultrasound score. So when we saw that you have ultrasound scores between 0 to 5 as given by the IOTA classification, suppose you have solid area with a blood flow. So you have a 0.5, you have a CA125 of 250. So 250 into 5 into menopausal status, which is 3. So it's, really high. So anything over 200 is definitely, RMI more than 200 is definitely indicative of malignancies. So all the American and Canadian guidelines say that a site is CA125 more than 200, abdominal distant mets, first degree relatives with breast and ovarian cancer must be referred to a gynecologist. And this is very important. This is a FIGO staging. So whenever we are dealing with adnexal masses and we suspect malignancy, we should never breach the capsule. So if we don't breach the capsule, we don't upstage the tumor. And this is very, very relevant, particularly in younger women where fertility is an issue. Because if you upstage, then you will have to give the patient chemotherapy if it's malignant, because you've spilled the contents into the peritoneal cavity if you're doing minimally invasive surgery. Now, after morcellation or after spillage, the tumor biology also gets altered, and then it becomes a challenge for us to do gonadoprotection for the other contralateral adnexa. Now, so whenever you have a laparoscopy versus laparotomy in picture in your mind, please always see the characteristics of the lesion on imaging. Look at the markers, see the suspicion you have for malignancy, and then only decide on a minimally invasive route. So, should you aspirate? Well, not all masses should be aspirated. Aspiration also causes microspillage. Now, there was an adnexal mass. The surgeon went in, saw a normal ovary, and thought this must be just some cystic lesion, and just aspirated the lesion. It was a wandering parasitic leiomyosarcoma, which was degenerated. So, you could have surprises. You could have things in the body which may not predispose or elicit themselves earlier. But then, should you always rupture? Should you avoid unplanned rupture? Definitely. I usually don't do planned ruptures also, because if I'm dealing with a mass and I'm suspicious, then I would love to take it out intact. And that is where you save the other ovary as well, and don't predispose women to receiving chemotherapy. So morcellation and risk of malignancy have some relationship in almost all lesions, particularly malignant, and also in benign lesions. So when should you do a cystectomy versus oophorectomy? I would say borderline tumors, small tumors, you could do cystectomies. Definitely risk of recurrence is slightly higher versus an oophorectomy, but then that has to be understood and individualized depending on your imaging, on your markers, age, need of pregnancy, and all such things. So fertility preservation, when you do a surgery, everything is same, okay? But the thing is that you don't have to spill. You have to send the tumor intact. And if there is no gross visible disease anywhere else, you have to stage completely with preservation of uterus and the contralateral adnexa. Nowadays, we don't biopsy the contralateral adnexa unless until there's a lesion there. So any stage 1A invasive epithelial tumor, that means confined to one ovary. Unilateral malignant germ cell tumor, sex cord stromal tumor, borderline tumors, we can all go ahead with fertility preservation. In germ cell tumor, whatever stage, we say even up to stage 3, 4, we should preserve fertility because they are highly chemosensitive. And the chemo BEP, which is used for GCTs, is not gonadotoxic. So the comprehensive surgical staging stays. It has to be done. And we subject these masses to frozen section. Within 30 to 45 minutes, they give us. I'll show you some interesting cases. This is a lady who was referred to me at 27 years of age. She was undergoing a workup for infertility, primary infertility, nulliparous, and had an incidental ultrasound diagnosis of a 4 to 5 centimeter ovarian lesion, which was, very vaguely reported. On MRI, we saw that the complete ovary seemed to be replaced by that lesion. So I suspected it's a stromal tumor. And I got an inhibin B done. All her other markers were normal. CA125, CA 19.9, AFP, beta HCG, LDH, all 6 were normal. So I said, I told the treating gynecologist, please do a inhibin B. It came out to be 768. So obviously my first-hand diagnosis prior to surgery was a granulosa cell tumor, likely malignant in her age group, because you have more of the juvenile varieties in this age group. And we took her for surgery. I recommended an open surgery to the patient. The patient's husband spoke to me and said, ma'am, it's a very small tumor. Can't we just take it out laparoscopically? So I told him, if I cut and take out the tumor, even within the bag, I don't want to do that because that will rupture the capsule. It will make it difficult for the pathologist to even, tell it later and probably diagnose a benign versus a malignant tumor later. And I would have, if I take this out intact in a bag and I enlarge my incision or give a small fan and steel another 4-5 centimeters ka incision, so utne mein to I'll just do a unilateral salpingophorectomy and sort of explore. So he said, okay, go ahead. They consented and we did a midline small vertical incision, 4-5 centimeters in height. And this was sent intact to our pathologist, and it was a granulosa cell tumor. I did the washings earlier, and we did a infracolicomantectomy on peritoneal biopsies. And there's not much role of doing lymphadenectomy in these tumors, particularly at younger ages. So she was not upstaged. Now she's under follow-up, completed 1 year of surgery. We've advised her that she can undergo, take up a pregnancy after 1 more year. So 2 years from surgery, and there was no need for giving her chemotherapy at all because she was stage 1A. So these are large lesions. You need to take them out intact. We need to respect the integrity of the capsule. And this is a huge lesion. This is about 28 to 30 centimeters size lesion. My incision was from xiphisternum to pubic symphysis. This is another lesion. This is a very, very, very heavy lesion. It's a 32 centimeter size, pushing the liver up. And I just thought we'll take it out and it'll be easy. This is a stage 1A, mucinous cystadenocarcinoma of the ovary. The lady is 82 years old. She presented to the emergency with breathlessness. So this is interesting, you carry a 32 centimeters lump or a mass in the abdomen and you still don't feel any pain. You could be so asymptomatic. And the only reason you've come to the emergency is because now you can't breathe. And the reason why it took me so much of time to make the son understand that she's not able to breathe because of this. It is not because of any, primary pulmonary issue. So he said, can't we wait for 2.5 months, my children's exam? We have to arrange social support and all kinds of things. So I said, no, she can't breathe. There is no space in her abdomen. Her diaphragm is getting pushed. And to my surprise, we had the entire transverse colon plastered to the lesion. It took me almost 2 hours for me to take this lesion. I was 21 kgs lesion, huge one. And this is the entire extent after I've dissected the transverse colon away. And I had to literally, spread it out on a green sheet to be able to understand and show. It looks small here, but it was huge, amazingly huge. And this is a torsion. The moment you open, you see a bluish discoloration. You can be absolutely sure that this is a torsion. And this exactly was what it was. And malignant lesions also can have torsion. So, you have to pop them up with an intact capsule. I have a horde of these masses bilobulated. This one's also malignant. And you can see the fallopian tube stretched over it. Always dissect the ureters well. Don't be in a rush to apply clamps. Sometimes ureters really go through the capsule of the mass. And if you are in a haste to take the lesion out, because that's what most people do, then you can actually do a ureteric injury. So with large masses, with any masses, it's a protocol for my unit. We always dissect the ureters. Absolutely. And, you have to dissect them perfectly well before you apply your clamps. So, huge lesions. I just did a 3 day back. I did a 6.2 kg malignant mass in a 59-year-old. She says she's been obese on the abdomen for 20 years. And now after menopause, when there's been muscle wasting, so she's realized that the weight is actually all over her abdomen. So she kept on thinking this is weight. This is probably, her abdomen. But then it started being asymmetric, thin legs, thin hands, and a whole protruded abdomen. And that's when she thought of going to a doctor. And it was a 6.24 kg mass in the ovary, which was malignant. Again, a mucinous one. So this lesion is interesting. This is from one of my patients only, and this lady was 67. I actually operated 2 days back her very good friend with C endometrium. So she came to see her in hospital. So after all the lecture that I had given them that all women should do their ultrasounds every year after 35 to 40 years of age, she said, let me go and do an ultrasound. So when she did an ultrasound, it showed a 5 centimeter cyst in the ovary. Now, again, it was not very well characterized. So I said, go ahead and do an MRI. Endometrium was not thickened. But the day when she came for admission earlier, it was just after COVID time. So she was wearing a cap and a mask, so I didn't realize. But the day she came for admission, I said, there's a lot of virilization, there's a lot of frontal balding. Let me do a DHES and testosterone was very high. So, sometimes you can have androgen secreting tumors in the ovary, which may be non-malignant. So this came out to be a non-malignant tumor in the ovary, which was testosterone secreting. But that's the beauty of doing an annual ultrasound. So if you have something which is even non-malignant, and I have a patient who's been religiously doing her ultrasounds, our post-menopause every year in her regular checks. So usually we have a tendency of doing thyroids, sugars, ECG, echo, lipid profiles, but we don't ever include an ultrasound and a mammo and a pap to it. I think for women that is the message, that pap and HPV DNA every 5 years, a mammo after 40 every 2 to 3 years, and after 50 every year, and an ultrasound after 35 every year for everybody, all women. I think that is something which can, decrease our chances of malignancies, and also picking them up early. If you couldn't prevent, probably you could. Cervical cancer, we can 100% prevent. Ovarian cancers, we can detect them in a non-malignant cystic sort of lesion where you could intervene. So this patient has been religiously doing an ultrasound every year for the last 7-8 years. 2 years in COVID, 3 years in COVID, she couldn't do. She had a 4 centimeter cyst in the ovary, which was static. And immediately it became 9 centimeters. So I said, 9 centimeter postmenopausal, we should take it out. CA125 was normal, everything was normal. It was only a cystadenoma. But before a cystadenoma, we have to understand that cystadenoma is also a precursor lesion. Cystadenomas only become borderline and then they become malignant. So that's the pathway. So I think this is one thing which is very important and crucial to women's screening and health checkups and packages. So these are bilateral solid cystic ovarian masses. And this is a coiled up fallopian tube on the top. Behind the uterus, I've just held the Cornwall lens to elicit these masses better. And we have to remember that comprehensive surgical staging is the key, whether you're doing fertility preservation or you're doing complete staging, whatever it is. So you have to have an adequate midline vertical incision. Never hesitate to increase your incision rather than struggle and rupture the masses. Frozen facility, if available, is a blessing in disguise. And there was a lady whom I, in postmenopausal, 67 years of age, 267 was her CA125, and she had an 8 centimeter left ovarian simple cyst. So when I did her surgery, I was quite sure that this cyst looks benign on the CT. She had already done a CT before coming to me. So my pathologist said it's a non-malignant simple cyst. Then I said, but I can't explain the CA125. There seems to be no reason why CA125 will be raised. So please also, I'm sending the uterus, you do a frozen for the endometrium as well, though she has no bleeding and she has a thin endometrium. After that 20-25 minutes, he calls me up and says, this looks like an adenosarcoma. I was zapped. So I said, are you sure? He said, give me 10 more minutes. I've taken 3 more sections. Let me see. Then he called up and said, this is a high-grade endometrial stromal sarcoma. I'm confident. You go ahead and stage. So I did a pelvic and retroperitoneal lymphadenectomy, and to my surprise, on the final histopathology, 2 of her pelvic nodes, 1 on either side, were positive for malignancy. So I started off with a simple ovarian cyst with pain and heaviness, with a CA125 of 267, and I landed up in a 3C2 endometrial stromal sarcoma high grade. And my only worry was that I couldn't explain why her CA125 was raised, and just struck me that, okay, I have, the biopsy has not been done because endometrium was thin, there was no bleeding, no indication to do a biopsy. Let's just look at the endometrium also. And that was something to my surprise. So we have to individualize every patient and try and ascertain what combinations could there be. So multiple peritoneal biopsies, and this patient, actually the one which is shown here, is a 16-year-old with torsion of a mucinous borderline tumor. And now, of course, she's 23. She's doing well. The other ovary is fine. And we must not hesitate to do advanced radical procedures for optimal cytoreduction. We now talk of complete cytoreduction. We say nothing tumor should not be visible to the naked eye. And that is what our aim in ovarian cancer is. And we add HIPEC to interval cytoreduction patients. And disease which is on the bowel surface like this is ominous, because this is really bad prognosis. You cannot completely remove her bowel, and you never achieve a complete cytoreduction in these patients. And this is a challenge to us still. So I hope I get lots of opportunities to answer questions. Thank you for your patience.
Very well explained, ma'am. Though I think adnexal masses, they always be remain challenging for all gynecologists.
Yeah.
And all the patients should be given individualized management, and but our approach should be methodical. Madam, do you think the PET CT has a role pre-operatively in the adnexal mass?
In certain cases, like suppose, see, one thing is that if it is available and on ultrasound you're seeing a mental streaking, you're seeing ascites, then one investigation that you could go ahead and do is a PET CT. There is no harm, because you actually sort of imaging wise stage the tumor. Now I'll tell you a very interesting case. This girl was 27 years old, primary gravida, underwent her delivery through a cesarean section. During the cesarean section, the gynecologist noticed some whitish lesions on the fallopian tube. I'm telling you the exact operative note description. So she said she took a biopsy from those lesions, and they came out to be a high-grade serous carcinoma. And this report was there 4 days after cesarean, and the husband was in a panic state. Anybody would be. A child is 4 days old, and the first child, and her wife and his wife is recovering from cesarean, and you have a report of a fallopian tube high grade serous carcinoma. Anyway, we said, go, if we have to do a PET, we have to withhold breastfeeding for some time and all that. So we went ahead and we did a PET. To our surprise, she had liver mets. So high grade cancers, we have to understand that ovarian cancer begins in the fallopian tube, and all high grade serous cancers, whether it's primary peritoneal or ovarian. So if you see features like ascites, if you see gross ascites, distended abdomen, 15 days history, or you one stop investigation can be do a PET CT. If you don't have a PET CT available, a CT abdomen and a thorax is a good idea. If you have gross ascites, always must evaluate the chest with not only chest X-ray but a CT as well. Because you may have sometimes, when you only do CT whole abdomen with contrast, on the lower sections, upper sections, you will get some slices of the lower field of the lungs. So you may get subeffusion. Always better to evaluate the lungs with a CT if PET is not available. Because effusion, if there is so much effusion, gross effusion, you are likely to be dealing with more advanced disease. There must be some peritoneal disease. The ability of PET CT to pick up peritoneal disease is definitely better than a CT. There is no doubt about it. They are not comparable. So we say that CT will pick up any disease more than 1 centimeter, whereas a PET CT will pick up disease more than 5 millimeter. So sensitivity that 5 millimeter
But
to
anyway, this pre-op diagnosis is going to affect our management or starting of giving some new adjuvant therapy.
Yes, of course, because this is going to change your plan of management. Now, if I have to go ahead and do a surgery for a patient, but she has an isolated liver met, I will not go ahead and do a surgery, because hepatic parenchyma or lung parenchyma is stage 4 disease. So I would like to give systemic treatment, because already hematogenous spread has happened. The cancer cells have traveled through the bloodstream to go into the parenchyma of the lung and the liver. So I'll not go ahead and do surgery, because that will delay my systemic therapy by about at least 4 weeks. I won't be able to give. So that is why I would want to know it this earlier, either by a CT or by a PET CT, depending on our resources.
We were talking like, suppose there is an adnexal mass without any ascites, any mats, then how are we going to demarcate
Ma'am,
and go the other way.
first step is ultrasound. Ultrasound mein if there is no ascites, no abnormal feature, only solid cystic, you can go ahead, do an MRI whole abdomen with contrast and a chest X-ray. That's fine.
And the markers also, na? Some
And the markers
markers.
also, of course. I mean, imaging
I
wise, I'm
mean,
saying MRI
combined.
and chest
Yeah.
X-ray should be fine. Then look at the age of the patient. If the patient, if on MRI you don't see any fat suppression images, you are not suspecting a germ cell or a teratoma or something like that, and the woman is above 40 years of age, you don't have to do AFP, LDH, and beta HCG. Then you can only focus on doing a CA 125 CA. When you are looking at the imaging, you will know the contents of the cystic part of the lesion, if they are there,
Yeah.
if they look mucinous, then please add CA and CA 19.9.
Hmm.
In
Here,
cases where there is no normal ovary and you feel that there is the whole involvement is of the stroma, please add inhibin B. Now, suppose if you have a postmenopausal woman, she has presented with postmenopausal bleeding, right? And the ovary is bulky. You did an MRI and there is a 3 centimeter lesion in the ovary. Please think of granulosa cell tumor. They can also present with
this
postmenopausal
is
bleeding.
postmenopausal.
So, must in these cases, we must do an inhibin B.
And
Here,
that's true.
I
Mhm.
want to add, ma'am. Actually, being gynecologist, we are now doing ourself ultrasound. I think self doing ultrasound in max. I think definitely you are getting very good reporting from
Mom, I'm not doing
radiologist.
my ultrasounds. I'm not doing my ultrasounds myself.
But
Neither
ma'am,
when
here, yeah, I am from here for
from
gynecologist.
small
I'm really.
city,
We should not
Gorakhpur.
treat the reportings. Clinical
Yes,
Yes.
I
correlation is
agree.
very important.
I agree.
So,
So, in all our advanced imaging, na, like MRI, CT, we take decision based on image or the scans, the serial scans. We see the sections. We don't go by the report. We
yes, yes,
always
Yeah,
it
see
is
the
like
very
image.
important.
she has said, na, cut off
Yeah.
200 for CA 125 cut
And
off is
also
that.
imaging, ma'am, you will know how much
Uh,
solid area.
Yes,
We
yes,
always
volume,
show
yes.
to our
volume.
patients also.
And there's also a criteria, na, something about the ovarian volume, like it should be 20 ml or so. If it is beyond that, so be suspicious.
Yeah.
Is it like that? Huh?
Ma'am,
It's,
even on the ultrasound, if you're having slightly bulky ovary reported by somebody
yeah,
and there
yeah.
is a persistent symptom, don't hesitate to do an MR. Sometimes I've
Mm,
seen one patient recently, she
mm,
had a bulky ovary on the ultrasound, constantly postmenopausal spotting. When I did an MRI, there was a 1.2 centimeter tumor,
mm,
very small focus of
But
granulosa,
that was a
granulosa cell.
mm.
case of postmenopausal bleeding. Patient had symptoms.
Yeah.
And what
Postmenopausal,
about
so you
your
can remove.
what
Yeah,
many centers they don't have frozen section.
yes.
What do you think the cut section in OT by
No,
ourselves
no,
can
no.
help us to
We
some
can't. No,
extent?
no, 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 ma'am. No, we can't.
Macroscopic examination.
No, 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 no. We should
Yeah,
not.
I remember I had
Hmm.
a case long back. Like doctor treats all the oncology. Being a gynecologist, I'm saying. She came, infertility. Infertility and fever, pain, all that. Okay, I did ultrasound personally because here in Gorakhpur, everyone knows to do ultrasound, basic ultrasound. And then I suspected because I was not very sure since she was an infertile case and she had a big ovarian cyst, big one with septa and all those things. I was suspecting it to be malignant, but I was not very sure. So I asked some other expert ultrasonologist to repeat. And he said कि कुछ नहीं malignant नहीं लग रहा आप ऑपरेट कर दीजिए. So when I operated on her because it was a big mass, I saw puckered areas over it. You know, like puckered malignant type,
Malignant
which I had
lesion. Hmm.
ग्रॉस पैथोलॉजी में पढ़ा था हम लोगों ने कि ग्रॉस में ऐसा दिखता है malignant और नॉन malignant में स्मूथ सरफेस नहीं था कि सिस्टिक हो. So I was suspecting. Now I didn't know what to do. And I saw on the other side also. The other ovary was also having, well, it means like if this was football size, then that was around orange size, but the same pattern. I didn't know what to do. Then I called the father of the daughter, and though she was married, father had come with her. Not her husband was standing outside, just waiting for the decision. कि क्या decision मिलता है. Because that I came to know later on. After I told that both the ovaries appear to be malignant, you tell me, should I remove one or should I wait? Means like, here we can't do frozen section. So I'll send it. I was in dilemma. Okay, I'll send it to the histopathologist. I'll close because she's infertile. I have to leave one ovary. Should I leave the smaller one or not? But then father took decision. Mankind, it appears to be malignant, but it is not.
Ma'am,
And
there are
I
2
was,
points.
listen, 15 years हो गया. दस
हम्म
पंद्रह-
मैम उस समय
That
ठीक था
time,
बट आज के टाइम में ना मैम
हाँ,
2 चीजें प्रॉब्लमेटिक हैं. नंबर
yeah.
1, अगर अगर कोई मेडिको लीगल इशू होता है, मतलब मेडिको लीगल
Exactly,
कैसे
I
होगा?
get your point, but I'm
हाँ.
telling, like
हम्म
these things, like Reeta was saying, na, yeah, frozen section
हम्म
is not there. I was talking, I just
So
remembered
the
because of
courts
that.
are usually of the view that if a facility is not available, either you refer patient, you tell the
Yes,
patient and
yes,
refer on paper to the higher center.
yes.
Otherwise,
नहीं, ये
the
बताओ
second
मुझे.
the second is you have to consent them for a second surgery. Introp
Yeah,
introp
yeah.
Yeah.
consent does not hold valid if the patient is major.
Hmm.
है ना?
She
If
was
you
major,
हाँ,
and I wanted to have a second
yeah.
look because that only I had studied and I was knowing. And but they were not ready for a
If
second look.
patients are unwilling to
And
go to a
uh,
center which has a frozen section and they want to be
No,
operated,
definitely, ma'am.
then second
Such type of patient who involve their bilateral lesions,
yeah.
and
uh,
we diagnose
and
it
gross pathology.
pre-operatively, and we know the
Uh,
fertility would be an issue for the frozen should be
which
available for this patient
should be
during OT.
available.
Absolutely.
And now we in BRD Medical College, we have started in frozen section. We
That's
are doing
very
all
good. Great.
adolescent and reproductive age group. We are doing frozen section,
Yeah.
and we are taking our
How
decisions.
many years
Absolutely.
it has
And
started?
one,
Frozen?
ma'am, 4 5 months.
Four,
Since
five
4 5
months.
months, and
Huh?
yes, we are
That
doing
is
now
also,
regularly.
yeah,
No,
good.
that's a
And
blessing for your
introp,
patients. Yes.
yes,
Blessings. Ma'am.
before that we used to refer patient.
Yes.
It was very clear that if there is no frozen section, it is
Yes.
injustice to do open this patient in
Bilateral.
our
Yes.
center. Yeah,
Yeah,
if
yeah,
it's
yeah.
reproductive age group needs fertility,
Absolutely.
bilateral lesions, we know it pre-operatively. Then we always used to consult and refer
Then
patient.
that's what I'm saying. Then he took decision and he said कि आप मैडम ठीक है एक निकालिए हो सकता है दोनों निकले या ना निकले तो अभी इसको बच्चे अच्छे करने हैं तो then after that again when one came malignant we had to treat her and then meanwhile she developed ascites also
Mm.
and then he stopped the treatment.
Mm.
He didn't take the treatment. He said, now she can't produce child. Her husband is also leaving her. She'll go back home. She'll stay
That's
with me
very
till
sad.
she's there. मायके में रही फिर वो पता नहीं क्या हुआ उसका. She was left for follow up. She didn't turn up. But another case I know, which doctors have had done radiation, and Madam Gina, she had operated. I know her very nicely personally, but she is alive till now.
Mm.
Mm.
Ma'am, tumor biology in sometimes in very young girls, na, tumor biology is a major challenge. So the old dictum which we used to have, na, that younger people have more aggressive tumors, which
Yeah.
is quite true now also. So, that is the case. You see 19, 20-year-old girls with CA rectum, Krukenberg being referred for ovarian dermoid surgery. I've had patients like this. When I did a PR, there was a rectal growth. We got a biopsy done. It was CA rectum. So CA rectum, bilateral masses, मुझे dermoid के लिए surgery, वो Krukenberg थे दोनों. So अभी वो, prognosis of a 19-year-old with a Krukenberg is so bad.
So bad.
And these
Yeah.
are not the patients which you should operate. They should be put on palliative chemotherapy. तो वो मतलब पूरा आपका the whole scenario changes completely. So correct evaluation, not hesitating to do a PR, doing a good breast evaluation in all our patients. They present with abdominal pain, they present with bleeding, have to do a speculum. I think our basic history and examination will do 70% of our work.
Yes.
Yeah, most difficult decision is for the infertile patients or those who want more children. There is problem. Otherwise, so you can take decisions,
Yes.
whatever. And many a times they have come with masses, and because it was mostly they come second stage and later on. So they were done with pre-op chemo or something, doctor gives, and after that operation, and then followed by the type of malignancy and treatment. Doctor will give his expert
In fact,
thoughts.
any adnexal mass must be thoroughly examined. PR is very important because most of the time you are able to assess the size of the tumor and extent and primary disease in rectum as well, as Dr. Swati said. So we must do thorough examination. Ultrasound must be done after 35 years as suggested for every woman so that we can find out, because once the ovarian tumor becomes bigger one, it is very difficult to treat. So that should be detected early. So ultrasound must be done for each and every female, at least every once or twice a year, after 35 of age, and then 55 every year. So that is very important. And whenever you suspect, you do all the list of investigations. That is most important. Bilateral cooking bulk tumor, most common, but unilateral you may find. And before operating, every liver and lung must be evaluated, because mostly we find a small lesion in the ovary or tumors somewhere, and we find so many metastases in the liver. So it's a very nice discussion, and you three, you have done very good job. You have
Dr.
explained.
Swasti and Dr. Reeta, really hats off to you.
Yeah.
You're a good speaker and very good chairperson. We have Rita is always ready
That's
to
the
come
problem
and
what you
help
are
us.
facing.
I've faced so many problems, and many times I think what to do and what not, and we must keep abreasting ourselves with the knowledge. And Swasti has done full justice to our topic,
Wonderful.
and very crisp, very nice pictures I saw. And Dr. Rita, you have to say anything? Please
No,
add
ma'am.
your
No,
conclude.
excellent talk, ma'am. Yeah.
Yeah,
Yeah, so
enjoy.
the message is very clear that history and proper examination. And I also say that all the gynecologists, at least I do ultrasound of my patient, the evaluation of the ovarian mass, adnexal mass myself. I have seen the patient who referred to me for ovarian mass, and there was ancested collection of collection in pelvis, and that was tubercular. So there are many
Yeah.
different. So I do my ultrasound myself, and the learning is not very difficult. Uh,
Mhm.
and there is definitely after that ultrasound gives a clue. And if you there is ascites and you think pleural effusion, gross disease, you suspect that you should go for MRI. MRI will or PET CT. This, if you get any metastasis, this will alter your management, and the patient will be candidate for the neoadjuvant therapy. That's all. And thanks to Dr. Swasti.
Thank you, ma'am.
Mhm. Thank you, Dr. Swasti. And so we wind up. Where is Dr. Diksha? Are you there? Conclude the webinar.
Thank you, Dr. Swasti ma'am, for sharing your valuable time and information amongst us and enlightening us with the knowledge less discussed about. Thank you, chairpersons and experts, for giving your valuable time and opinion to our listeners. And thank you, Clirnet, for helping and supporting us always. Thank you.
Thank you all. We'll see you again in some other webinar. And thanks all the participants. Forgot to mention them because this is a separate faculty link and the delegate link. So thanks all for the participation and seamless, uninterrupted talk and interaction. Thank you all once again. Okay.
And thanks to you, ma'am, Dipti ma'am, for
Thank you.
organizing this
Okay.
webinar.
I
Thank
love
you,
to
ma'am.
do all
Keep it
study
up.
part. Thank you.
Thank you.
Thank you.
Thank you.
Thank you, Diksha, for the first debut. Okay.
Thank you for giving
Thanks for
opportunity.
the first debut. Okay, bye.
Bye.
So
Okay,
leave, ma'am?
bye.
Okay.
Yeah, sure. Okay, thank you.